Guillain-Barré Syndrome, or GBS, is an acute, immune-mediated, demyelinating polyradicular neuropathy, most commonly presenting with rapidly progressive symmetrical ascending weakness. It is the most frequent cause of acute flaccid paralysis worldwide. The classic variant is acute inflammatory demyelinating polyradicular neuropathy, though axonal variants also exist, such as AMAN and AMSAN. GBS often follows an infectious trigger, commonly Campylobacter jejuni, but also cytomegalovirus, Epstein-Barr virus, Mycoplasma pneumoniae, or even recent vaccination or surgery. It is thought to arise due to molecular mimicry between microbial antigens and components of peripheral nerves. Clinical features include symmetrical ascending weakness, starting in the legs and progressing to the arms and cranial nerves. Areflexia or hyperreflexia is characteristic. Sensory symptoms are mild or absent, often presenting as glove and stocking paresthesia. Cranial nerve involvement is common, especially facial palsy, which often affects both facial nerves. Autonomic dysfunction is common and may include blood pressure lability, arrhythmias, or urinary retention. Respiratory compromise can occur, so always assess forced vital capacity. Diagnosis is based on clinical suspicion, with supportive findings including cerebrospinal fluid analysis showing albuminocytologic dissociation, which is elevated protein with normal white cell count, usually seen after the first week. Nerve conduction studies show slowed conduction velocity and prolonged F waves, indicating demyelination. MRI of the spine may show enhancement of spinal nerve roots, but is not routinely needed. Differential diagnoses include transverse myelitis, which has upper motor signs and a sensory level, myasthenia gravis, which is characterized by fluctuating weakness and spared reflexes. Management consists of intravenous immunoglobulin at 0.4 grams per kilogram per day for 5 days, or plasmapheresis, which are equally effective if started early. Steroids are not effective. Monitor for respiratory failure. If forced vital capacity is less than 20 milliliters per kilogram, consider intensive care and possible ventilation. Supportive care includes deep vein thrombosis prophylaxis, pain control for neuropathic pain, and physiotherapy. Most patients recover over weeks to months. 20 to 30% require ventilation. 5 to 10% mortality occurs, often due to autonomic instability or respiratory failure. The chronic variant is chronic inflammatory demyelinating polyradicular neuropathy, which is considered if the disease is progressive for more than 8 weeks. Variants to know include Miller-Fisher syndrome, which presents with ophthalmoplegia, ataxia, and areflexia, and is anti-GQ1B positive. AMAN and AMSAN are axonal types that are more severe and common in Asia. Bickerstaff brainstem encephalitis presents with encephalopathy and GBS features.
Subscribe to the Medical Mind YouTube channel.